Hi guys, welcome back. So today we are gonna be talking about a lot of things. So we're gonna go over topic 2, 3, and 4. So on the syllabus, topic 2 is about Breathy Arrhythmias. So disorders of the sinoatrial node and disorders of the AV node. Topic 3 is about supraventricular tachyarrhythmias, and topic 4 is about ventricular arrhythmias. So I know it's quite a lot, so I probably have to split this video into different parts, but essentially we're just going to be talking about arrhythmias. So let's start by first defining what an arrhythmia actually is. So an arrhythmia is simply the abnormal electrical activity within the heart. So what can go wrong? So what can be abnormal? So we can have an abnormal rate, abnormal rhythm, abnormal like origin of the impulse, or problems or abnormal sequence of the conduction, right? So again, we can have we can have like an abnormal rate, an abnormal rhythm, an abnormal origin of the impulse. Recall that the impulse should be coming from the SA node, and abnormal sequence of conduction. So recall that the normal sequence goes from the SA node to the AV node to the bundle of His, the Purkinje fibers, okay? So that's the normal conduction system of the heart. So, right, how am I gonna do this? Okay, so the most common way of classifying arrhythmias is based on rate. Recall that the normal rate is between 60 to 100, okay? So that's our normal range. So if our heart rate goes below 60, what do we call this? We call this Breathy Arrhythmias, okay? So it can be any type of slow rhythm disorder. So if the rate falls below 60, this can be any type of Breathy Arrhythmias. If the rate exceeds 100, this can be any type of Tachyarthmias, okay? So it's just a way of classifying arrhythmias. Too slow and too fast, right? So let's first turn our attention to tachyarrhythmias. So tachyarrhythmias, any arrhythmias that has a fast heartbeat, a heartbeat that exceeds 100, right? So there are two subgroups of tachyarrhythmias. So we have supraventricular tachyarrhythmia. So these are tachyarrhythmias occurring above the ventricles. Supra means above, ventricular means ventricles. Tachyarrhythmia means fast, irregular heartbeat. Yeah, not irregular, so just fast heartbeat, okay? So the other one is ventricular tachyarrhythmia. So, okay, I want this to make sense. Okay, so we have tachyarrhythmias. So any arrhythmias exceeding 100 beats per minute. We have two subgroups. We have supraventricular tachyarrhythmias and we have ventricular. So supraventricular happens above the ventricles, like for instance in the atria or the AV node, and ventricular tachyarrhythmias occurring within the ventricles. So we have different types of supraventricular tachyarrhythmias. So we can get sinus tachycardia. So sinus tachycardia is when the impulse is coming from the SA node. That's why it's sinus. But it's tachycardia because it's sending impulses way too fast, right? So we call this a sinus tachycardia. So that's the first type of supraventricular tachyarrhythmia, sinus tachycardia. The second one, we can get atrial tachyarrhythmias. So atrial tachyarrhythmias are due to irritable areas within the atria that fires and send impulses to the AV node even before the SA node gets the chance to fire and send an impulse to the AV node, okay? So if we have just one irritable foci firing, if we have one irritable area or focus in the atria firing at a faster rate than the SA node that sends impulse to the AV node before the SA node even gets a chance to fire and send impulse to the AV node, we call this a focal atrial tachycardia. Focal atrial tachycardia. If we have multiple areas that are irritable and firing faster than the SA node. We call this multifocal atrial tachycardia. Okay, so I hope that makes sense. Right. So we can also get re-entrant circuits, okay? So if we have one re-entrant circuit, for instance, like we have like another irritable area at the tricuspid area that's creating a loop, a re-entrant circuit, we can get atrial flutter, right? So I'm just gonna give you guys an introduction. Obviously, I'm gonna go over this in much more detail later on, but I'm just trying to name the different types of arrhythmias, okay? So again, back to what I was saying, if we have a re-entrant circuit, for instance, at the tricuspid area, just one re-entrant circuit, we can get atrial flutter. If we have multiple re-entrant circuits within the atria, then we can get atrial fibrillation, okay? If we have a re-entrant circuit in the AV node itself, okay, we can get an atrioventricular nodal re-entrant tachycardia, or an AVNRT, atrioventricular nodal re-entrant tachycardia. If the re-entrant circuit is via an accessory pathway looping between the atria and the ventricles, then we can get an atrioventricular re-entrant tachycardia, an AVRT, okay? So those are the different types of supraventricular tachyarthmias. So again, supraventricular tachyarrhythmias happen above the ventricles. This includes sinus tachycardia, focal atrial tachycardia, multifocal atrial tachycardia, atrial flutter, atrial fib, AVNRT, AVRTs. By the way, AVNRT and AVRTs are sometimes called PSVT, so paroxysmal supraventricular tachycardia, okay? So those are basically, PSVT just refers to AVNRT and AVRT, okay? So I hope that's clear. Moving on to the ventricular tachyarrhythmias. So these are tachyarrhythmias occurring within the ventricles, okay? So we can get ventricular tachycardia. So ventricular tachycardia happens when we have an irritable focus within the ventricles firing so fast, generating a very fast rhythm within the ventricles. So that's ventricular tachycardia. And by the way, we have two types, okay? If we have just one area firing within the ventricle, then we get monomorphic ventricular tachycardia. Monomorphic ventricular tachycardia. If we have multiple areas in the ventricles firing, then we get polymorphic ventricular tachycardia. And with polymorphic ventricular tachycardia, again, there's two subtypes. So we can get a polymorphic VTAC with normal QT interval. Again, I'll discuss this later. I just want you to know the different types of arrhythmias that we can encounter. Okay, so back to what I was saying. So polymorphic VTAC, we have two types. We have polymorphic VTAC with normal QT, and we can have polymorphic VTAC with a prolonged QT interval, which we also call torsades de pointes. It has a special name. Polymorphic VTAC with prolonged QT interval is called torsades de pointes. Okay, so another one that we can get is we have like multiple re-entrant circuits within the ventricles. Then we can get ventricular fibrillation. Moving on to bradyarrhythmias. So bradyarrhythmias are any arrhythmias that have a slower than 60 beats per minute heartbeat. So what do we have? So we can have sinus bradycardia. So sinus bradycardia simply means that the sinoatrial node is not firing as fast as normal. So the impulses it generates isn't getting a 60 to 100 beats per minute heartbeat. So it's less than 60. So we have sinus bradycardia. It's sinus because it's originating from the sinoatrial node. Bradycardia because it's just too slow. Sinus bradycardia. Right. So for bradyarrhythmias, this can also be caused by conduction blocks or heart blocks. So the SA node could be firing at a normal rate, but the AV node is just like not doing its job properly. So it's like either delaying the conduction or not conducting the signals from the SA node at all. So in any case, we call this a conduction block or a heart block. First degree heart block, second degree heart block, and a third degree heart block. So a first degree heart block is basically, it's not too serious. So the AV node is just delaying the impulse from the SA node a lot longer than it should delay the impulse for, okay? But it still conducts the impulse. It just delays it for a little bit longer than normal. That's the first degree heart block. Second degree heart block, we have two types. We have Mobitz type 1 and Mobitz type 2, and I'll go into this in a lot more detail later. A third degree heart block is the worst that you can get. A third degree heart block or a complete heart block means that the atria and the ventricles are beating independently of each other. So the AV node really isn't listening or isn't conducting any impulse from the SA node, right? So that's a summary of tachyarrhythmias and bradyarrhythmias, summary of the different types of tachyarrhythmias and bradyarrhythmias. So before we move on to talking about the different causes of brady and tachyarrhythmias, I just want to briefly mention that we have this very, very interesting and unique disorder where we get both bradycardia and tachycardia at the same time or within the same disorder. So we call this the sick sinus syndrome or the tachybrady syndrome, I think. So sick sinus syndrome happens when we have a dysfunctional SA node, whether that's dysfunctional because it's fibrotic or there's scarring in the air in the SA node, meaning that it doesn't beat as fast, okay? So if it doesn't generate impulse as fast, then we get sinus bradycardia. And because we get sinus bradycardia, some areas within the atria, they try to compensate for the sinus bradycardia by firing. So they become like anectopic foci. They fire faster than the SA node, creating a supraventricular tachycardia. So they create an SVT. So whether that's via an atrial flutter, atrial fibrillation, or just a PAC, premature atrial contraction, the point is they try to compensate for the sinus bradycardia by making some irritable foci within the atria, creating an SVT that then leads to tachycardia, right? So basically, sick sinus syndrome is we have a dysfunctional SA node that's not firing as fast. So we get intermittent bouts of bradycardia with concomitant compensatory tachycardias via an SVT. So via an atrial fibrillation, atrial flutter, or a PAC. Now let's talk about the causes of arrhythmias. So first of all, arrhythmias can be caused by either the increase or a decrease in automaticity. So an increase in automaticity is most often associated with sinus tachycardia. So an increase in automaticity means that we activate our sympathetic nervous system, which releases adrenaline and noradrenaline, and it increases the conduction via the SA node, increasing our heart rate. Okay, so what are the things that cause or the factors that lead to an increase in automaticity? So if we, for example, are hypovolemic, so we have very low fluid level in our body, that activates the sympathetic nervous system. So a decrease in blood volume means a decrease in blood pressure, right? This creates a reflex response of vasoconstricting our vessels as an attempt to increase our blood pressure, and it also increases our heart rate, okay, as again an attempt to pump more blood into the circulation throughout the whole body. So hypovolemia can increase automaticity because of that reflex response, reflex vasoconstriction and reflex increase in heart rate. Hypoxia can also cause an increase in automaticity. So hypoxia can be caused by various things. So for instance, if someone's anemic, so they have low red blood cells, then they can be hypoxic. Also, if the person has chronic lung disease like COPD, they can also be at a hypoxic state. If someone has a PE, which is a clot that has traveled to the lungs and is occluding, the vessels, then again, the person could be in a hypoxic state, which triggers an increase in automaticity, right? That's why for patients coming in with a PE, one of the most common signs would be sinus tachycardia, an increase in heart rate, okay? Right. Another thing that can cause an increase in automaticity is sympathic mimetics. So these are just drugs that mimic the function of the sympathetic nervous system. So like cocaine, methamphetamines, things like that. Also, pain and anxiety can cause an increase in automaticity because pain and anxiety activates our hypothalamus, which is part of the limbic system, activating the sympathetic nervous system, and therefore, increasing our heart rate. Another thing can be an increase in metabolic activity of the cells. So, because an increase in the metabolic activity can increase the electrical activity between the myocytes. So, for instance, if we have fever, or if we have hyperthyroidism, that's going to increase metabolic activity, increasing electrical activity, and therefore increasing the automaticity. To go over that really briefly, causes of an increased automaticity, which then increases our heart rate, causing sinus tachycardia, include an increase in the sympathetic nervous system tone. So triggers can be hypoxia, hypovolemia, like sympathic mimetics, drugs that mimic the sympathetic nervous system action. So we can get like increase in metabolic activity because of hyperthyroidism or fever, and pain or anxiety because that activates the hypothalamus within the limbic system, activating sympathetic nervous system. So those are the causes of increase in automaticity. Decrease in automaticity means that there is a higher parasympathetic outflow, which releases acetylcholine, decreasing our heart rate, causing sinus bradycardia. So causes of a decrease in automaticity include increase in vagal tone when we're sleeping or resting, any drugs that slows down AV conduction like beta blockers, calcium channel blockers, digoxin, a decrease in metabolic activity, for instance, someone's hypothermic or hypothyroid, and imbalances with the electrolytes, so hyperkalemia, because that changes the resting membrane potential, and finally an increase in intracranial pressure leading to brain herniation and the precipitation of the Cushing's triad, which decreases our heart rate. So those are so increase or decrease in automaticity can lead to arrhythmias, more specifically sinus brady or tachycardia. The second cause of arrhythmias can be triggered activity. So triggered activity is more commonly associated with tachyarthmias as opposed to bradyarrhythmias. So triggered activity basically means that we develop some irritable areas within the ventricular or the atrial myocardium that then starts firing, and the impulse doesn't follow the normal conduction sequence. It doesn't follow SA node to AV node to bundle of His to Purkinje fibers. It doesn't follow that. So we precipitate an arrhythmia. That is the very definition of an arrhythmia, an abnormal conduction sequence. So triggered activity or these ectopic foci can start firing, and the impulse doesn't follow the normal conduction sequence. So they can produce two different types of depolarization called an early after depolarization or delayed after depolarization. So these two can have different underlying causes and can precipitate different types of arrhythmias. So starting with early after depolarization. So early after depolarization is most commonly associated with polymorphic VTAC. Specifically, the type of polymorphic VTAC with the prolonged QT, which we call as Torsades de Pointes. So causes of an EAD or an early after depolarization include imbalances in electrolytes. So for instance, low potassium, low calcium, also drugs such as antibiotics, anti-arrhythmics. So there's a mnemonic, there's A, B, C, D. So A is for anti-arrhythmics, B is antibiotics, C is it's antipsychotics. It's not spelled like that, but just remember C is antipsychotics, D is antidepressants, like your tricyclic antidepressants, and to some extent your SSRIs, and E is for antiemetics. So again, causes of EADs include imbalances in the electrolytes like low potassium, low magnesium, low calcium, and then other drugs such as antiarrhythmics, antibiotics like your macrolides, antipsychotics like your haloperidols, antidepressants like your TCAs, TCAs, and your SSRIs, and antiemetics. And EADs are most commonly associated with polymorphic VTAC with a prolonged QT known as Torsades de Pointes. Delayed after depolarization, on the other hand, can be caused by other things like ischemia. So for instance, if the patient has coronary artery disease or an MI, it can also be caused by hypoxia. So we can get hypoxia, for instance, if we're anemic, so low red blood cells, or if we have chronic lung disease like COPD. And DADs can also be caused by an inflammation in the myocardium called myocarditis. Also, like an increase in the stretch of the myocardium. So if we have like mitral regurg or dilated cardiomyopathies, so those can cause DADs. So DADs are most commonly associated with like multifocal atrial tachycardia, focal atrial tachycardias, as well as polymorphic VTAC, but polymorphic VTAC with the normal QT as opposed to the prolonged QT, which is Torsades de Pointes, because Torsades de Pointes are more commonly associated with EADs. So the third cause or potential mechanism that may lead to the development of arrhythmias is re-entrant circuits. So re-entrant circuits, they are mostly associated with tachyarthmias, so your fast arrhythmias. And re-entrant circuits can precipitate different kinds of tachyarthmias, and we'll talk about some of them today. So they can precipitate your PSVTs, so your proximal ventricular tachycardias, including your AV NRT and your AVRT. The second one, they can precipitate atrial flutter and atrial fib. And re-entry circuits can also lead to ventricular tachycardia and ventricular fibrillation, which are your deadly ventricular tachyarrhythmias. So starting with how re-entrant circuits can cause SVTs. So let's first recall this that SVTs, we have SVTs just refer to AVNRTs and AVRTs. So how does a re-entrant circuit cause an AVRT? So let's focus on AVRTs for now. So AVRTs, or atrioventricular re-entrant tachycardia, can be caused by a re-entrant circuit. So in AVRT, there is an accessory pathway involved. So an accessory pathway basically just links the atria and the ventricles. So in the case of AVRT, the most common type is Wolff-Parkinson-White syndrome. So in Wolff-Parkinson-White syndrome, we have an accessory pathway called the bundle of Kent. So the bundle of Kent kind of like connects the left atrium and the left ventricle, and it's a bidirectional pathway. It's very important to remember this, because in a bidirectional accessory pathway, it means that impulses coming to the atria that goes through that pathway going to the ventricles can travel the other way as well, from the ventricles through via that pathway to the and back to the atria. So it can go both ways. It's a bidirectional accessory pathway. So okay, there are two types of AVRTs. So I just want to make sure that AVRT is clear. So AVRTs are caused by an accessory pathway, okay? And an accessory pathway just means that we are linking the atria and the ventricles with each other, okay? And the most common type of AVRT is Wolff-Parkinson-White. Well, no, it's one of the most common, Wolff-Parkinson-White syndrome. And in Wolff-Parkinson-White syndrome, the type of accessory pathway we have is the bundle of Kent, right? And we have two types of AVRTs. We have orthodromic and antidromic AVRTs. In orthodromic AVRT, what happens is the SA node fires, the impulse travels across the atria and then into the AV node. The AV node conducts that impulse down to the bundle of His, up to the Purkinje fibers. And guess what happens? Usually, in a normal conduction system, it stops there. SA node, AV node, bundle of His, Purkinje fibers, done. But in this case, because we have an accessory pathway on the left ventricle and the left atrium, linking them together, the impulse travels back up to the atrium. So this is the conduction sequence in orthodromic AVRT. So we have SA node firing, travels to the whole of the atria, to the AV node, down to the bundle of His, up to the Purkinje fibers, through the accessory pathway, the bundle of Kent, back into the atrium, okay? So it goes like that, yeah? So in orthodromic AVRTs, because it sort of follows the normal conduction system, SA node, AV node, down to the bundle of His, Purkinje fibers, and then the accessory pathway, then back down to the AV node, bundle of His. Because it follows sort of the normal conduction system, this actually produces narrow QRS complexes. So this is how we make that distinction. So orthodromic, narrow QRS, and because it follows the normal conduction sequence, okay? In antidromic AVRT, what happened, this is less common, but it still happens, and it's much more dangerous because in this situation it goes the other way, okay? So the impulse is generated in somewhere in the atria, and then what happens is that impulse, instead of traveling down to the AV node, it travels down to the bundle of Kent. So somewhere in the atria there's an irritable foci, fires, and then goes to the bundle of Kent, instead of going to the AV node, down to the ventricles, up to the bundle of His, up to the AV node. So we've kind of reversed the conduction sequence in this case, okay? So in antidromic, because we've kind of reversed the sequence and we're not, because it goes from atria, bundle of Kent, down to the ventricles, up to the bundle of His, up to the AV node. What we're doing is we're reversing the conduction sequence, meaning that the QRS complexes that we would see would be wide instead of narrow, right? Another important thing, because it goes the other way around, because it goes through that accessory pathway instead of going to the AV node, this is extra dangerous because it means that in some cases, the atrial rate may equal ventricular rate. Recall the atrial rate is much faster than the ventricular rate. So, if every time that the atria fires, the signal gets sent down to the ventricles instead of going to the AV node, which is regulated. So AV node is regulated. So if the impulse comes from the sinoatrial node or somewhere in the atria, goes to the AV node, the AV node slows down that conduction. The AV node knows what it has to do. It slows it down it's well regulated. It slows the conduction down. It doesn't just conduct every single time that the atria fires. Whereas this bundle of Kent, it's not regulated at all. So every time the atria fires, if the impulse goes through the bundle of Kent, it's always gonna depolarize the ventricles. So now you can see why it's very dangerous, why we can get really, really fast arrhythmias in this way through this bundle of Kent, because it's not regulated. It doesn't slow anything down. It doesn't block any conduction. It just conducts. Every time the atria conducts an impulse, it sends it down to the ventricles, back up to the bundle of His, and back up to the AV node. So that's why it's more dangerous than the orthodromic AVRTs. Now let's discuss the re-entry pathway or the re-entry circuit in AV and RT. So in AV and RT, which is atrioventricular nodal re-entrant tachycardia, the re-entrant circuit is actually within the AV node itself. So we have an abnormal re-entrant circuit within the AV node, right? So within the AV node, what happens is because of prior MI, we have had some scarring or fibrosis in the tissue within the AV node, or maybe because of previous surgery, we have damaged some of the cells, and therefore they have gone fibrotic, or it's been replaced with like scar tissue or something. So when the atria depolarizes, it goes through the AV node. And from the AV node, what happens is that impulse bifurcates. So we have the alpha pathway and the beta pathway. So in the alpha pathway, we have the fibrotic, the scarred tissue, and the beta pathway, we don't have any scarring or any fibrosis. So the atria depolarizes. The impulse goes to the AV node, and then from there it bifurcates the alpha pathway with the fibrosis, the scarring, and the beta pathway without any damage. And then after that, it goes down to the bundle of His, to the right and the left bundle branches. So the atria depolarizes, impulse goes to the AV node. The alpha pathway, because there's fibrosis, it's gonna be a much slower conducting pathway. So conduction in the alpha pathway is slow, but recovery period is fast. On the other hand, the beta pathway, the conduction will be fast because it doesn't have any scar tissue, but the refractory period will be longer. Okay, so this is what happens. Again, atria, they depolarize, signal goes to the AV node, signal bifurcates to the alpha pathway, the slow conducting pathway, and the beta pathway, which is the fast conducting pathway, and then it goes down to the bundle of His, and then the left and right bundle branches. The second time it happens, atria depolarizes, signal to the AV node, because the beta pathway is still in refractory. Remember that the beta pathway takes a much longer time to get past that refractory period compared to the alpha pathway. What happens is, because there's this pathway, the beta pathway, is still in refractory, the impulse has no choice but to go to the alpha pathway. So it goes through the alpha pathway, which is the slow conducting pathway. And by the time it reaches the end, just before it goes to the bundle of His, guess what happens? The beta pathway now starts to come out of refractory. So once beta pathway starts to come out of refractory, the signal here, before it goes down to the bundle of His, goes back up to the beta pathway, up to the atria, depolarizes the atria again, and then sends the signal back down to the AV node, bifurcates, because this beta pathway is still in refractory. It has no choice but to go to the alpha pathway. And by the time that signal reaches the end of the alpha pathway before the bundle of His, the beta pathway comes out of refractory, and boom, it sends signal back up to the atria. So we have this circuit, we have this loop, this re-entrant circuit within the AV node. And this is what causes an AV-NRT. This re-entrant mechanism, this re-entry circuit is what causes an AV-NRT. Alright, so The other types of arrhythmias that can be caused by a re-entrant circuit, as I said at the beginning, are atrial flutter and atrial fibrillation, as well as VFib and VTAC. So let's go over the atrial tachyarthmias first. So in atrial flutter, we have a single re-entrant circuit. So in atrial flutter, most commonly that re-entrant circuit is located at the tricuspid area, the tricuspid valve area. So I think it's called the cavo-tricuspid isthmus, I think. So basically there's a re-entrant circuit there, which depolarizes the atria over and over again, causing an atrial flutter. That's just one re-entrant circuit in the tricuspid valve area, causing the depolarization of the atria. Okay, so in another scenario, if you have multiple re-entrant circuits within the atria, then this can cause an atrial fibrillation. So in atrial fibrillation, because multiple ectopic foci are just firing, and they have their own re-entrant mechanism, the atria, they can't actually contract in a synchronized manner, they're just fibrillating. So that's what happens during AFib. Re-entrant circuits can also cause VFib and VTAC. So in VTAC, we have one re-entry circuit somewhere in the ventricle causing a re-entrant circuit, causing the ventricles to beat super fast, causing ventricular tachycardia. In VFib, we have multiple re-entrant circuits going on, causing the ventricular myocardium to just fibrillate. So they are not beating in a synchronized manner. So these can all be caused by re-entrant circuits. And finally, another reason why we can develop arrhythmias is if we get any conduction blocks. So conduction blocks are mostly associated with bradyarrhythmias, or your slow arrhythmias. So for conduction blocks, there are many different causes. So one can be fibrosis within the AV node. So for instance, if we've had like prior MI or any damage to the AV node, which means that some of the tissues get replaced with scar tissue which do not conduct at all, meaning that the conduction at the AV node can be blocked either completely or partially, stopping or slowing the conduction via the AV node. We can also, if we stop blood flow to the AV node, that can obviously hinder the transmission of the impulse. So the coronary artery that supplies the AV node is the right coronary artery. So if we have, for instance, an inferior MI, an occlusion in the right coronary artery, then we would stop blood flow to the AV node, meaning that we're slowing down or we're stopping conduction via the AV node, leading to conduction blocks. Other things that may cause conduction blocks include Lyme's disease. So Lyme's disease, it's caused by a bacteria from ticks. So that can also lead to conduction blocks. Another thing would be imbalances like hyperkalemia, because that just alters the resting membrane potential. And then finally, we can also get infiltrative diseases. So we can get deposits within the myocardium. For instance, the buildup of the protein called amyloid, like amyloidosis, influencing or hindering actually the conduction through the AV node. And actually, we can also have drugs as well, slowing down the conduction via the AV node. So for instance, if we give the patients any calcium channel blockers, beta blockers, or digoxin, that may precipitate conduction block. So that may slow down or impair conduction via the AV node.